Hello and welcome to Pain Management 106. This is a sixth lecture in a series of lectures structured around pain management. So in this lecture, we will be talking about different therapeutic interventions. So let's talk about proper drug selection. So let's start with opiates. So opiates are drugs that are really well known in the realm of pain management, and you're probably all well familiar with these drugs. These are oxycodone, codeine. This is a common ingredient in different cough formulations. For example, Tylenol with codeine syrup, morphine, and oxymorphone, also commonly known as Dilaudid. So morphine was first isolated in 1806 by a German pharmacist, and ever since then, even during American Civil War, it's been used extensively, and it's very effective for the treatment of severe pain. So let's look at opiates and their mechanism of action. Opiates have a variety of different mechanisms of action, but most importantly, what they do is they're going to inhibit release of excitatory neurotransmitters, and they're also going to promote release of inhibitory neurotransmitters. They increase threshold for the action potential generation. So remember when we talked about pain signal originating in your body, and it's basically propagating from the peripheral nervous system to the central nervous system. So what opiates do is they increase the threshold to generate an electrical potential so that the signal never really originates and you can't propagate something that's not there. And lastly, they also activate opiate receptors, which is going to prevent the action potential propagation. So let's talk about opioids and compounding. So when a lot of people think about opioids and compounding, the two don't seem to really go well together, but it's actually counterintuitive because there's definitely a clinical niche for the use of compounding in patients who are taking opioids. Again, we talked about that opioids are very effective in relieving pain. So the three main mechanisms that they use to relieve pain is they basically reduce release of inflammatory neurotransmitters. They also reduce the output of the neurons, and they inhibit neural activity via GABA. But because they're so effective for relieving pain, there's no denying that they're going to be used, meaning, you can't just imagine that somebody who is in severe pain just won't be placed on an opioid, or somebody who is a clinically appropriate candidate for opioid that they should be denied an opioid. What we can think about is using compounding as an adjunct method or tool for decreasing opioid use. Meaning, if you have a patient who is currently taking opioids for pain because they have very severe pain, perhaps they sustained a injury to their spinal cord, how you can market and how you can think about compounding is that you can actually use compounded preparations to decrease opioid burden. Meaning, if somebody is taking like 100 milligrams of an opioid, now maybe they could be taking only 50 milligrams, because in addition to taking those 50 milligrams, they're able to get some pain relief from a topical compounded cream that they're using. You can also think about it as a method of reducing pill burden, because who likes to be taking pills all day? Nobody. So they're taking a lot of pills throughout the day because they're scheduled on a short-acting drug. Now, by using this compounded preparation, maybe you can improve their quality of life by reducing their pill burden. Another way that you can think about compounding when it comes to opioids is that opioids have a lot of side effects, and we will talk about them. But because they have so many side effects, you can market a compounded cream as a means of reducing their opioid dose and also trying to avoid some of the side effects and also trying to avoid some of the potential for abuse and addiction. Another thing that you need to be aware of is that not every kind of pain will respond to opioids. For example, soft tissue pain will be highly responsive versus something like nerve compression or neuropathic nerve destruction that leads to neuropathic pain is going to be moderately or maybe perhaps even non-responsive in this case. So opioids are not the answer for every single kind of pain. Another thing about using opioids that you need to be aware of is that they have a potential for development of tolerance dependence, and addiction. So what is tolerance? Tolerance is basically when your organism no longer responds to a drug, you build up a tolerance to it. That means to achieve the same therapeutic effect, you need to be taking higher and higher doses of the drug. So maybe to achieve pain relief, instead of taking 10 milligrams like you've been taking for the past several months, now you have to take 20 milligrams. Dependence is when your organism only functions normally in the presence of a drug. So if you wake up in the morning and you just don't even feel like yourself, you feel like you're a deer in headlights, you don't understand what's going on until you had your morning cup of coffee, that means your body or your organism is physically dependent on caffeine to function normally. And then addiction is basically compulsive use of a drug despite harmful consequences. So what this means is that somebody is using the drug even though maybe they're causing direct tissue harm or injury to their body. For example, in Eastern Europe, there's an illicit substance known as crocodile. It's a very highly addictive drug, but injecting it can cause severe body damage. For example, you can cause an infection, an osteomyelitis of the bone, or severe infection of the soft tissue, and people tend to have their limbs amputated when they use this drug chronically. So addiction would be using crocodile even though you may have to have your arm amputated after you using this drug. So you are aware of harmful consequences, but you still continue to use it. So we talked about before, opioids have a lot of side effects and toxicities. What are they? Well, constipation is a really big one. It may not seem like much, but trust me, if you are sort of clogged up or unable to go for a prolonged period of time, like a week, which is very common with patients who are taking opioids, you will be completely miserable. You will feel bloated. You just feel like you're unable to function. So constipation is actually a pretty substantial side effect of opioids. Also, nausea and vomiting, sedation, and respiratory depression is a very dangerous potential adverse effect of using opioids. Also, opioid dependence, we talked about it briefly, but all opioids have agonist properties that basically interact with deep brain structures that affect the reinforcement and reward. So that means that estimated about 5 to 10% of the population actually have a predisposition to addiction. And other factors that are going to increase your likelihood are use of other addicting substances, for example, alcohol, nicotine, and of course, social and psychological factors. And you need to identify those patients. Why? Not to shame them or create some kind of social barrier, but just so you can structure the administration of drugs in such a way as to reduce their potential for misuse and abuse. Opioid diversion is another big problem with opioids. So addiction is not the only concern. Misuse and abuse are far more common. Why? Because opioids, you can sell them on the street. People get high off of them, and they actually go for a lot on the street. So diversion is definitely a big problem to worry about with opiates. And now let's talk about a different class of drugs. These are called antidepressants, and they're basically exactly what they sound as. They are traditionally used for the treatment of depression. For example, tricyclic antidepressants is some of the longest known drugs for the treatment of depression. But, ironically, these drugs also treat pain really well. And they do it by several different mechanisms, including basically blocking neuronal uptake of different neurotransmitters such as serotonin. So basically, you're going to inhibit spinal neurons that are part of the nociceptive perception. And another thing that they're doing is you're blocking sodium and calcium channels. And if you remember, these channels on the cells are responsible for generation of electrical potential. Remember when we talked about the 4 processes of pain signal transmission up the afferent nervous system, so from the periphery all the way up to the brain. So origination of pain signal transduction is the very first stage. So here what you're doing is you're blocking the origination of pain signal, so there's nothing transmitted or propagated. Antidepressants actually have a lot of side effects when they're taken orally. So they're not as safe as they may seem. And their side effects can be summarized in this beautiful mnemonic. So some of the side effects are you're going to be hot as a hare, so they cause hypothermia. Mad as a hatter. This is a hatter from Alice in Wonderland. And basically they refer to the fact that they can cause CNS side effects or delirium. Blind as a bat. They can cause blurred vision. Dry as a bone. You can have dry skin. And red as a beet. So they can cause flushing. And then when somebody starts oral antidepressants, for some of them, it's actually mandatory that you get an ECG prior to treatment because they can cause cardiac conduction disturbances and they have potential for fatal dysrhythmias or cardiac arrhythmias, and they also have a potential for weight gain, which I know is very important for some people. In topical form, they're very safe. We use amitriptyline. This one specifically, amitriptyline, has been shown to be very effective in certain neuropathies, for example, post-herpetic neuralgia or diabetic neuropathy, and it may be also effective for relief of pain after stroke. So we use amitriptyline 2%. This provides adequate analgesia and has minimal potential for side effects. At the same time, it has well-established clinical efficacy in case reports. So thank you so much for your time, and we will be moving forward and continuing with our lectures to review the next classes of drugs.